the second part of our lecture dedicated to the basics of the computed tomography. Can you hear me? Everything is okay?
Yes, everything is great.
Okay. So it's such a funny image, but actually it's not always funny for the patient, because sometimes it's actually a magnetic resonance imaging device. Some patient got a claustrophobia, and it's not always possible to, without any problem, to perform the X-ray, CT, or especially MRI imaging, because MRI gantry deeper and bigger, and in some patients we must perform sedation before the performing magnetic resonance imaging. And some patients, it's very important to perform such kind of the imaging. Without it, it's impossible to perform precise diagnosis. So it's sometimes not so easy. So if we will talk about the previous part of the lecture about the plain X-ray imaging, we must mention that plain X-ray image, it's just a one plain image performed in one or more projections, and very limited three-dimensional data could be achieved during the plain X-ray imaging. Yeah, it gives us more details compared to the nuclear techniques, but still it's impossible for us to perform three-dimensional reconstructions of the organs. That's why computed tomography gives us much more anatomical information, much more possibilities in the diagnostics of the different pathologies, especially tumors. So as written on this slide, plain film imaging reduces the 3D patient anatomy to two-dimensional projection image. Yeah, the projectional image. Density at given point on an image represents the X-ray attenuation properties within the patient along a line between the X-ray focal spot and the point on the detector corresponding to the point on the image. And on this slide, you already can see the slice through the patient's body, abdominal region, during the computed tomography. This is kidney, this is liver, this is gases inside the bowels. So when we will remind to us the classification of radio density, it's very close when we compare plain X-ray image and computed tomography image. We can see the vessels here. We will talk about them a little bit later. So with conventional radiograph, information with respect to the dimension parallel to the X-ray beam is lost. And this limitation can be overcome to some degree by acquiring two images at angle of 90 degrees to one another, as you saw in the previous part of the lecture, plain X-ray imaging of the lung, yeah, in two projections. But still, it's not enough sometimes. For objects that can be identified in both images, the two films provide location information. But still, it's not enough, especially in case of the tumors, to precisely detect the size, shape, and invasion of the tumor into adjacent tissues. So that's why the tomographic imaging was invented. The tomographic image is the picture of a slab of the patient's anatomy. The two-dimensional CT image corresponds to a three-dimensional section of the patient. You can just imagine that you have a bread, and you slicing the bread. You want to make a sandwich, and you slicing the bread. Yeah, the same way we achieve the slices during the computed tomography, but not only in this one projection, but always also in the second and third projection. So all in three projections, like a Descartes three-dimensional axis. Yeah, the slice, the thickness of such slices could be very thin, even to 1 millimeter or 10 millimeter, and it's approximately uniform. The 2D array of pixels on the computed tomography image corresponds to an equal number of 3D voxels, volume elements in the patient. So the voxel, it's a name for the three-dimensional pixel in the computed tomography. And each pixel on the CT image displays the average X-ray attenuation properties of the tissue in the corresponding voxel. Here you can see the schematic presentation. This is a pixel, and this is a voxel. Voxel is three-dimensional thing. And this is the pixel. And this is the grid. And this amount of the pixels, the more pixels there will be in the image, the higher radiation dose the patient will receive, because the higher resolution of the image, the thinner slices will be, the higher radiation dose patient will achieve. This is the principle of the CT. The tube which emits X-ray waves rotates around the patient. From the opposite side, there is an individual detector which can capture the X-ray wave, and depending on the energy of this wave, the image will be registered and formed on the monitor. And this is the stationary detector array. So this tube will rotate around the patient all the time. The older devices with the X-ray tube rotation around its X obtain the table translation, and it means the patient moved along with the table, and after one rotation there was small pause, and then table moved for 1 millimeter, for instance, and the next scan was performed. And it was not a perfect type of the scanning due to the artifacts, and that's why later on the more modified and more precise technique was invented, so-called helical X-ray tube, and it's passed around the patient. It's shown on this image. So this so-called spiral computed tomography, which allows, due to this spiral movement, to decrease distance between the slices and achieve the most precise anatomical information with minimal amount of the artifacts. So today we got such type of the CT devices, spiral multi-detector computed devices. Very important to understand the projections. Usually we perform imaging in the 3 projections, but sometimes due to the radiation, ionizing radiation that the patient will be exposed to during each projection that is applied, we may decrease the amount of projection. So, for instance, perform only axial, which is obligate, usually always axial projection, and only coronal or sagittal. If it's very important to achieve some anatomical information, we may perform CT imaging in all 3 projections, but remember that each projection, it's once again we scan the patient, and once again we expose it to ionizing radiation, which is actually a little bit, not even little bit, but dangerous due to the possibility to the cancer development, because X-ray waves, it's high energy waves, they may cause the mutation, the aberration, the damage in DNA system of the cell, and cause the secondary so-called radiation-induced cancer. So you must remember always to decrease radiation dose in your patients, and always ask your patients, have you already underwent the X-ray examination or nuclear examination this year, and what was the dose? The dose always must be recorded on the paper, on the report, and you must calculate this dose. In the books, you remember from previous semester that we got 4 groups of patients. Group AD, it's a patient with the oncological pathology, or whom oncological pathology is suspected. In those patients, the maximal annual limit of the dose is 100 millisieverts. Yeah, and if we'll talk about the computed tomography, one CT, multi-phase CT with a contrast may reach the dose even up to 25-30 millisieverts. So it means that if you will perform such 3 CTs per year, you will reach this limit. Yeah, and in patients without oncology or in whom oncological pathology is not suspected, they will be in a group BD. The maximal annual dose is only 20 millisieverts. It means that maximally one computed tomography during a year could be performed. Yeah, and now we got a COVID situation, we got a pandemic, and a lot of doctors prescribe computed tomography of the chest many times just to monitor, to perform dynamical surveillance for those patients, forgetting that it's dangerous to perform many computed tomographies of the lungs. And we await during the next 5-10 years a high an increasement of the rates of the lung cancer due to such a attitude of some doctors. And we got alternative methods of the imaging, like ultrasonography of the lungs, like a magnetic resonance of the lungs, in order to perform the scanning, monitoring, and avoid radiation exposure on the patient. So regarding these projections that you saw on the previous slide, we can see 4 axial slices, yeah, through the patient's body, and coronal and sagittal projection. Very important to achieve 3-dimensional information. This is not only the slice through the patient's body, but different contrasting phases. This is a phase before the contrast. We call it native phase before the contrast. As you can see, if we're not using the contrast, and usually the contrast is iodine containing, injected intravenously using special injectors, bolus injections, it's not much of tissue contrast. It's hard to assess the different parts of organ. That's why we usually use contrasting, especially when we suspect the tumor. You can see this is the kidneys, the right kidney, the left kidney, and we can see a huge tumor within the right kidney, and you can compare pre-contrast image and post-contrast image. On pre-contrast image, it's very uneasy to assess the margins of the tumor and say how this tumor is only located within the kidney and maybe infiltrates into the liver and other organs like pancreas and so on. And after the contrasting, we can see these different organs much more better. This is arterial phase, this is aorta, we can see it here. We can see kidney vessels, this is vessels, this is vessel. Yeah, aorta, it's very bright because it's containing contrast. Yeah, this is aorta. Without contrast, it's much more darker. This is renal, this is vena cava and renal veins here. This is renal vein. And the second post-contrast image, we call it a nephrographic phase. We can see the renal parenchyma much more also here. And third is called excretory phase, when the contrast is excreted into the pelvic ileal system of the kidney. Yeah, it's just the main principles of the CT imaging. You will read much more. As you can see on this image, the interpretation of the radio densities, it's very close to plain X-ray. Air, it's dark in the lung, yeah, and soft tissues are gray, bones are bright, radio opaque, yeah. We call it of high radio density or low radio density. You can see here air in the bowels, skin. This is the fat, yes, fat, muscles, bones, so kidney, cortex, parenchyma, vessels, arteries, veins, liver. So very easy to differentiate. And what is very important, based on this technique on computed tomography, we may perform 3-dimensional reconstruction of the organs. Right now, it's not presented here, but very close to this image, we got such a cinematic CT. When we see on 3-dimensional reconstruction, the image that you saw in the anatomical museum of our university. It's almost like a photography. So many anatomical details are preserved, and this is so natural that it looks not like a computed tomography image, but like a photography after you will just slice through the human body and look at the organs. It's like anatomy, real anatomy. So it's on such a high level, this type of the imaging right now. But sure, the higher resolution we obtain, the higher radiation dose we will apply. So it's always very important to remember and obtain a balance between the radiation dose and the resolution that we want to achieve. Maybe we don't need such high resolution. If we don't need the excretion phase of the contrasting, we should not perform this excretion phase, because for each phase of the contrasting, we need to perform scanning through the all parts of the body again, or abdominal region, yes, for instance, again and again and again. So each contrasting phase increases one more time the radiation dose. So it's very important to remember. Here you can see different examples of the 3D reconstructions of the skull vessels, of the skull itself, abdominal region, kidneys, vessels of the kidneys. This is CT angiography. Also, we may have MR angiography, magnetic resonance angiography, and here you can see CT angiography, imaging technique which allows us to assess the vessels. Heart in 3 dimensions. We can see coronary arteries. Yeah, so it's very, very beautiful scene, and we can rotate, we can delete, cut through the organs just in order to leave the tumor, for instance, or vessels of our interest. So how you may, in the end of our lecture, improve your radiology skills. You can use radiology books that I already supplied. My students of my groups, I've sent into Viber groups different books you can share with them. Learning Radiology, it's a site with the different examples, clinical cases. Aunt Mini, also another very interesting sites. You can just Google the words you don't understand and look at the medical imaging, their meaning, and surf the websites of medical schools. This is all for today. I hope this lecture was informative, and for sure you must read literature in order to prepare yourself for the MCQs and for the practical seminars. I wish you all the best, and till the next lecture and till the next practical seminar. Bye.
Thank you, sir.